Imagine a patient whose internal engine is running so intensely hot that they are literally digesting their own skeletal muscle just to stay warm.
Right.
And all this while lying in a room that's heated to like 33 degrees Celsius.
Yeah, it sounds completely like science fiction.
It really does. But this is the chaotic, devastating physiology of a major burn. Welcome to this revision deep dive.
Exactly. And as plastic surgeons, we know firsthand the sheer, overwhelming volume of information you have to master.
Oh, absolutely. So this session is designed entirely for you, the resident preparing for board exams like the FRCS. Today's rapid-fire Q&A is going to cover the medical and surgical management of major burns.
Specifically, we're going to master fluid resuscitation and the systemic hypermetabolic response.
Right. But before we get to the first clinical scenario, just a quick reminder, hit follow on whatever app you're using right now to get more of these revision deep dives delivered directly to you.
And please rate the show if you find this session helpful.
Yeah, and if you want to take your exam prep to the next level, get a premium subscription to listen to the Journal Club and Clinical Cases episodes.
Excellent. So where are we starting today?
Well, we are starting at minute 0, the immediate aftermath of a major burn, those critical first 24 hours.
A golden window.
Exactly. When I teach this on the ward, I try to get juniors to visualize the vascular system not as solid pipes, but more like a woven fabric holding the blood and proteins inside.
That's a great way to picture it.
Thanks. But the massive inflammatory storm of a burn turns that tight fabric into a loose sieve. So can you walk us through the exact timing of this vascular permeability?
Yeah, that sieve analogy is exactly how you need to conceptualize it. The greatest fluid losses occur in that first 24 hours post-burn.
Right.
You get this massive systemic increase in vascular permeability. It allows fluid and critically vital proteins like albumin to just leak straight out of the intravascular space.
And they pool in the interstitial compartment, right?
Exactly. And the timing is highly testable. The rate of that leakage actually peaks around 8 to 12 hours post-burn.
Wow, 8 to 12 hours.
Yeah. This massive fluid shift, combined with the severe myocardial depression that occurs in major burns, creates what we actually define as burn shock.
So our goals have to aggressively combat both the empty vessels and the failing heart.
Precisely. We have 3 fundamental goals with our fluid resuscitation, and you should be able to recite these if asked.
Okay, let's hear them.
Number 1 is restore the circulating volume. Number 2 is preserve tissue perfusion.
Right, keep the oxygen flowing.
And number 3, which is absolutely critical for our eventual surgical outcomes, avoid the ischemic extension of the burn wound.
Got it. And we achieve this by administering large volumes of salt-containing fluid to prop up the circulation.
Right.
But I'm going to push back on the logic here because this is where it gets terrifying for the junior doctor on call.
Oh, it's totally daunting.
Right. It's the ultimate resuscitation catch-22.
Oh, wait.
If the fluid is leaking out of the vessels because they've turned into a sieve, isn't pouring more fluid into those vessels just going to make the peripheral swelling worse?
Yes.
I mean, we're basically flooding a house because the pipes are broken.
It is a profound paradox, and you've hit on the exact tightrope we walk. The burn edema itself is what drives the burn shock, because the fluid is leaving the vessels.
Yeah.
But the massive fluid resuscitation we are required to give to save the patient's life drives even more burn edema. It's a necessary evil.
So we just have to accept the swelling to keep the heart pumping.
Exactly. Because of this extreme physiological cost, we don't just start dumping fluids into everyone with a blister. We have strict, calculated thresholds.
Right. The cutoffs.
You only initiate formal fluid resuscitation for adults with burns over 15% total body surface area.
And for children.
For children, it's any burn over 10% TBSA.
Okay, so we are trading one problem generalized edema to prevent a fatal one, which is cardiovascular collapse.
Exactly.
Now that we understand why we are forced into this paradox, let's look at the actual math and the fluids we use to manage that broken sieve.
This is where the examiners live.
Oh, absolutely. Let's talk formulas. Everyone knows the Parkland formula is the gold standard starting point. Break down the math for us.
Sure. So the Parkland formula dictates we give 4 melts per kilogram of body weight per percentage of total body surface area burn.
Okay, 4 mLs per kilo per percent.
Right. That gives you the total volume of Hartmann's solution for the first 24 hours.
But I want to push on the specific fluid choice, too. Don't just tell me Hartmann's solution.
You want the breakdown.
Yeah, the FRCS examiners love to test the exact electrolyte breakdown. What is the recipe and why are we using it?
They absolutely will test those numbers
Yes.
and the rationale behind them. But first, let's finish the Parkland timeline.
Oh, right, the halves.
Yes. You give half of that total calculated volume in the first 8 hours. You give the second half over the next 16 hours. And here is a crucial exam trap. That time is calculated from the time of the burn, not the time the patient rolled through the hospital doors.
Right. If the patient sat in a field for 4 hours waiting for an ambulance, you only have 4 hours left to aggressively infuse that entire first half of the fluid.
Exactly. You are constantly fighting the clock. Now, for the exact makeup of Hartmann's solution, you need to commit this to memory.
Let's hear it.
Sodium is 131 millimoles per liter. Chloride is 111.
Okay, sodium 131, chloride 111.
Lactate is 29, potassium is 5, and calcium is 2.
Let me repeat that for the listener. Na 131, Cl 111, lactate 29, K5, Ca2.
Perfect.
But why the lactate? I mean, why are we giving lactate to a patient who is already in shock?
Well, because it acts as a buffer. The liver metabolizes that lactate into bicarbonate, which helps buffer the severe metabolic acidosis that these patients develop from tissue hyperperfusion.
Brilliant. That makes perfect sense. Now, Parkland is the classic, but Charles Baxter, the surgeon who actually described the Parkland formula, he did a massive review on its real-world efficacy, didn't he?
He did.
And the truth is, it's not a magic bullet, is it?
Far from it, actually. Baxter found that his own formula is accurate in only about 70% of adults.
Just 70.
Yeah. It actually overestimates the requirement in 18% of patients and underestimates it in 12%.
So it's a starting point, not a Bible.
Exactly. Where Parkland really falls down and is notoriously inadequate is in massive burns, those over 80% TBSA, and in older patients, specifically those over 45 years old.
And when it underestimates, the instinct for a junior is to just keep pouring in more crystalloids.
Which is dangerous.
Right. The complications of that are severe. We are talking pulmonary edema and notoriously abdominal compartment syndrome.
Yeah, where the bowel swells so much it compresses the vena cava and just shuts down the kidneys.
So how do we avoid flooding the system with crystalloids?
To mitigate those massive fluid shifts, specialized burn units use colloid-sparing strategies.
Okay, colloids.
The logic is simple. If the vessels are a sieve, put something big and sticky in the blood to hold the water inside. We introduce a colloid.
When exactly do we introduce it?
Some units introduce it after 8 hours, precisely because that's when the peak vascular permeability finally begins to decrease.
That 8 to 12-hour window we mentioned.
Right. Others wait for 24 hours. This brings us to the Muir and Barclay formula, which is the other major calculation you absolutely must know.
Muir and Barclay completely flips the script. How does the math change?
Well, instead of crystalloids, Muir and Barclay uses human albumin solution.
Okay, HAS.
And it calculates the volume to be given over the first 36 hours following a burn rather than a 24-hour window. The multiplier is smaller, too. It's 0.5 milliliters per kilogram per percentage burn.
So half a millimole.
Right. That calculation gives you an aliquot, which is a specific volume of fluid. You infuse one of those aliquots in sequential stretching time periods.
Stretching time period.
Yeah, so 3 blocks of 4 hours, 2 blocks of 6 hours, and 1 block of 12 hours.
Okay, so the timeline stretches as the vascular leak seals up. 3 times 4, 2 times 6, 1 times 12.
You got it.
And a quick historical note for the exam here. We used to talk a lot about synthetic colloids, like hydroxyethyl starch or HES.
Oh, yes. You need to know that HES products have been withdrawn from the UK market.
Right, because of the trials.
Exactly. Randomized controlled trials showed an increased risk of mortality and severe renal failure in critically ill patients. So your colloid of choice is human albumin in adults, and fresh frozen plasma, or FFP, is often preferred in children.
Okay, so we have the fluids running, but formulas are just starting estimates. How do we know if it's working without making things worse?
That's the real challenge.
Let me set up a clinical scenario for you. You are the registrar on call in the ICU. You have a patient with a 40% burn, and you notice their urine output has dropped to near zero. A junior doctor, maybe fresh off a general intensive care rotation, says, blood pressure is soft. Let's start a vasopressor to squeeze the peripheral vessels and drive some blood to the kidneys. Why is that a catastrophic error in a burn patient?
It is a devastating mistake. Vasopressors work by clamping down the peripheral blood vessels.
Right.
In a burn patient, the peripheral tissue is already desperately starving for blood. If you use injudicious vasopressors, you actively worsen tissue hypoperfusion.
So you're killing the tissue you're trying to save.
You will literally deepen the burn wound by starving the surviving cells of oxygen. You'll transform a partial thickness burn into a full thickness one.
Wow.
And you will absolutely ruin any chance of a skin graft taking. You must remember this rule low urine output in the burn patient is hypovolemia until proven otherwise.
So treat the tank, don't just squeeze the pipes.
Exactly. You do not use drugs to treat low urine output without absolutely ruling out an empty tank first. You treat it with more fluid.
But what if the tank is full?
Now, if you have given adequate fluid and you are directly measuring cardiac output, ideally with a transesophageal Doppler to prove the heart is actually failing, then you can step in with pharmacological support.
Okay. And in that specific scenario?
In that highly specific scenario, the inotrope of choice to help the heart pump is norepinephrine, and the preferred vasopressor is dobutamine.
That distinction is crucial. So we are titrating fluids based on urine output. What are our actual targets?
Urine output is our best window into tissue perfusion. In adults, aim for 0.5 to 1 milliliter per kilogram per hour.
And for kids?
In children, their metabolic rate is higher, so the target is 1 to 1.5 milliliters per kilogram per hour.
And here is a highly tested exception, right? You must double those targets after high-voltage electrical injuries.
Yes.
Because electrical injuries cause massive hidden muscle destruction, which releases myoglobin into the blood, and that clogs the kidneys. We need high flow to wash it out.
Spot on. So 1 to 2 milliliters for adults, 2 to 3 milliliters for kids in electrical burns. Beyond urine, you must monitor the core to peripheral temperature gradient, looking for a gap that suggests peripheral shutdown.
Right.
And from your blood gases, serial measures of arterial blood lactate and base excess are your vital indicators of whether your resuscitation is clearing the systemic acid load.
Speaking of different targets, let's shift our focus specifically to children.
Good idea.
Pediatric burns are incredibly highly tested. I always try to push past the old cliche that a child is not a small adult. I think of it more like an engine.
How so?
Well, a small car engine revving at maximum RPM burns through its limited fuel reserves incredibly quickly compared to, like, a massive idling truck engine.
That analogy gets right to the physiology.
Yeah.
Children have a proportionally massive body surface area compared to their total mass. Think about an infant's head compared to their body.
Right, it's huge.
Because of that surface area, they lose heat and water much faster, and yet they have significantly reduced physiological reserves to cope with it.
So they crash faster.
Exactly.
Yeah.
Because of this, you cannot just use Parkland and walk away. Children require additional maintenance fluid on top of the resuscitation fluid.
And crucially, that maintenance fluid must contain dextrose to prevent fatal hypoglycemia,
Okay.
right? Because they simply don't have the glycogen stores in their tiny livers to keep their blood sugar up under that kind of stress.
Exactly right.
Walk us through the maintenance calculations.
The standard is the 150-20 rule for daily maintenance. That's 100 milliliters per kilogram for the first 10 kilograms of body weight.
Okay.
Then 50 milliliters per kilogram for the next 10 kilogram, and 20 milliliters per kilogram for any remaining weight.
Got it.
But for the actual burn resuscitation in kids, specialized units often abandon weight-based formulas like Parkland entirely and use the Galveston formula.
Why is Galveston better for pediatrics?
Because it is based on body surface area, or BSA. Given those wildly different surface area to volume ratios we just discussed, BSA is a much more accurate metric of how much skin is actually missing in weeping fluid.
So what's the math for Galveston?
Galveston dictates 1,500 kilocalories per square meter of BSA for maintenance, plus 1,500 kilocalories per square meter of the burn area itself.
Okay, let's transition here. The 24-hour fluid crisis eventually ends, but for the patient, the nightmare is really just beginning.
Absolutely.
Let's look at the systemic metabolic storm that follows. You see these patients in the ICU, and they can literally waste away right in front of you, losing massive amounts of muscle even when they are receiving continuous tube feeding.
It's terrifying to watch.
It is. Walk us through Cuthbertson's phases. Specifically, I want to understand the tragic irony of carbohydrate cycling.
This is one of the most fascinating and destructive processes in human physiology. Cuthbertson described the body's response to major injury in two distinct phases, the ebb and the flow.
Okay, ebb and flow.
The ebb phase is the immediate hypodynamic period. The shock state lasts in about 48 hours. But once you resuscitate them, they enter the flow phase.
So what does that look like?
This is a hyperdynamic, hyperthermic state that can last for up to a year. Cardiac output doubles. core temperature sets 1 to 2 degrees above normal, and extreme hypermetabolism sets in.
And what is actually happening at a cellular level to cause that muscle wasting?
The massive release of circulating catecholamines and stress hormones creates a severe diabetic-like state. You get rapid glycogenolysis, dumping glucose into the blood.
Right.
But here is the aha moment for the exams. The burn wound itself is a massive glucose consumer, but it metabolizes that glucose anaerobically. It doesn't use oxygen.
So it's terribly inefficient. It burns the glucose and creates massive amounts of lactate as a byproduct.
Exactly. That lactate floods back into the bloodstream and goes to the liver. The liver tries to help by turning that lactate back into glucose through gluconeogenesis.
But to do that, the liver requires a massive supply of amino acids.
Yes, and where does it get them?
Yeah.
By ruthlessly tearing down the patient's own skeletal muscle. This entire futile process is called carbohydrate cycling. The body is literally cannibalizing its own respiratory muscles and heart tissue just to feed a burn wound that yields only a tiny fraction of normal energy.
The body's eating itself to feed dead tissue. It's devastating. And there is a hard limit to how much muscle you can lose before the system fails completely, right?
Yes, a loss of greater than 40% of lean body mass is normally fatal.
40%.
Once you hit that threshold, the body can no longer mount an immune response, the respiratory muscles fail, leading to pneumonia, and wounds simply stop healing.
So since this hypermetabolic cannibalization is so destructive, how do we actively modulate it? Because standard hospital tube feeds are totally inadequate.
Completely inadequate.
Standard enteral nutrition is mostly fat-based, about 44% lipid. Why do we have to completely flip the nutritional script for burn patients?
Because standard feeds maintain body weight by depositing fat. They do not replace or save muscle. In a major burn, if you want to stop the liver from tearing down skeletal muscle, your feeding must be overwhelmingly carbohydrate heavy.
Now, how heavy?
A typical burn feed is 82% carbohydrate, 15% protein, and only 3% lipid.
82% carbohydrates. That is a massive sugar load. Why does that save muscle?
High carbohydrate diets heavily stimulate the body's endogenous insulin production. Insulin is our primary anabolic hormone. It drives protein synthesis and forces the body to build muscle rather than break it down.
Ah, I see.
Now, because of that stress-induced diabetic state, endogenous insulin often isn't enough, so we add exogenous insulin infusions to maintain tight glycemic control.
And that actively improves healing and decreases mortality.
Yes, you are aiming for a very specific calorie-to-nitrogen ratio of 100:1.
And what about specific amino acids? The examiners love to ask about the ones we call conditionally essential.
Glutamine and arginine. They are conditionally essential because on a normal day, your body synthesizes enough of them.
Right.
But under the severe catabolic stress of a major burn, your endogenous production can't keep up, and they become essential dietary requirements.
What does glutamine do specifically?
Glutamine is the primary metabolic fuel for rapidly dividing cells. Supplementing it improves wound healing and maintains the mucosal integrity of the gut, which stops gut bacteria from leaking into the blood.
And arginine.
Arginine enhances natural killer cell function and stimulates T lymphocytes, boosting the immune system.
Okay, so we're pumping them full of 82% carbohydrates to save their muscle. But all those calories won't matter if the patient is literally shivering away their energy reserves because their skin, their primary insulator, is gone.
Exactly.
Which brings us to the environmental thermostat. Why are burn units kept at a sweltering 28 to 33 degrees Celsius?
It's all about decreasing the metabolic burden. Burn patients lose huge amounts of water through evaporation directly from their open wounds. As that water evaporates, it pulls heat away from the body, causing profound hypothermia. If the room is cold, the patient is forced to burn their own precious muscle mass to generate the heat required to maintain their core temperature.
By shivering.
Exactly. By warming the room to 33 degrees, we provide external environmental heat to offset that evaporative loss. We warm the room so they don't have to burn their own muscle to shiver.
It makes perfect physiological sense. Now let's look at pharmacological modulation. Two medications are heavily tested here, propranolol and oxandrolone.
Propranolol is a non-selective beta blocker. It directly blunts that raging catecholamine storm. We titrate the dose specifically to decrease the patient's heart rate by 20%.
20%, okay.
By slowing the heart, you reduce cardiac work, dramatically decrease peripheral lipolysis, and lower the resting energy expenditure. The end result is less muscle wasting.
And oxandrolone.
Oxandrolone is an oral anabolic steroid. It directly decreases protein metabolism and promotes protein synthesis.
But steroids have side effects.
They do, but what makes it uniquely testable is its safety profile. Its virilizing androgenic side effects are only 5% of what standard testosterone causes, which makes it safe and effective to use in female and pediatric patients.
Brilliant. All right, let's move to the final major hurdle in burn management. Up to 75% of deaths in major burn patients are attributable to sepsis.
The wound is the perfect incubator.
It really is. The examiners will grill you on topical antimicrobial agents. So I'm going to throw a classic clinical trap at you.
Okay.
You assess a patient in the emergency department. They have what clearly looks like a painful pink superficial partial thickness burn. You apply silver sulfadiazine or SSD and wrap it up.
Standard protocol.
Right. The next day, you take the dressings off on the ward round, and the wound looks deep, leathery, and entirely full thickness. What happened? Did the burn deepen overnight?
This is a textbook trap. The burn likely didn't deepen at all. When you apply SSD to superficial burns, it chemically reacts with the wound exudate to form a thick, yellow-gray pseudochar.
Ah, pseudochar.
Yeah, it perfectly mimics a full-thickness burn and makes accurate assessment of the true burn depth incredibly difficult for the next surgeon.
What are the other key side effects of SSD they need to recall?
The most common systemic side effect is a transient leukopenia, a drop in white blood cells. Locally, it is actually toxic to fibroblasts, which means it paradoxically delays wound healing.
Oh, wow.
And crucially, you must completely avoid it in the final weeks of pregnancy, in premature infants, and in the first 2 months of life because the sulfonamide component displaces bilirubin and causes kernicterus, leading to brain damage.
Okay, let's look at some other highly tested topical agents. What about cerium nitrate mixed with SSD?
Often known by the brand name flamicerium. Unlike plain SSD, the cerium component aggressively reacts with the wound to form a hard, leathery antimicrobial ester with calcium deposition.
When do we use that?
We use it specifically for deep burns in patients who are too unstable for immediate surgery. It essentially mummifies the burn, preventing bacterial invasion while you wait days or weeks for them to be fit for theater.
And we are seeing a lot of nanocrystalline silver now, like Acticoat.
Yes, the manufacturing process creates a massive molecular surface area. When that silver matrix reacts with water, it provides a sustained, continuous release of silver ions and free radicals.
And that kills the bugs.
Yeah, it destroys bacterial cell walls over several days, requiring fewer painful dressing changes.
But what do we reach for when the routine swabs come back showing MRSA?
For localized topical treatment of MRSA, the agent of choice is mupirocin, often known as Bactroban.
Finally, a bit of an ancient remedy making a major comeback in modern units and highly testable on its exact mechanism, medical grade, honey. How does it actually kill bacteria?
It's a fascinating multimodal weapon. It doesn't just have one mechanism, it relies on 4. First, the bees add a peroxidase enzyme to the nectar.
Okay.
When applied to a wound, this enzyme continuously generates a slow, steady trickle of hydrogen peroxide. It's enough to destroy bacteria, but not concentrated enough to fry the delicate new human cells trying to heal the wound.
That's amazing. And the second mechanism?
Second, it contains plant-derived bioflavonoids that disrupt bacterial division. Third, it has a very low pH, around 3.6, creating an acidic environment hostile to pathogens.
And the fourth?
Fourth, its high sugar viscosity forms a literal physical barrier on the wound surface while drawing fluid out of bacterial cells via osmosis.
Incredible physiology. But despite all these amazing topical agents and advanced antibiotics, what is the ultimate definitive sepsis prevention strategy?
The ultimate strategy is the scalpel. Early surgical excision and wound closure.
Cut it out.
Yes. If you just carpet bomb a major burn with broad-spectrum antibiotics while leaving the dead tissue in place, you don't cure the patient. You just breed highly resistant superbugs like extended-spectrum beta-lactomases or ESBL Klebsiella and vancomycin-resistant enterococci.
Right, the worst ones.
Early excision physically cuts away the necrotic tissue. You are removing the warm, wet, dead substrate that bacteria feed on. By closing that wound with a graft, you restore the body's natural physical barrier.
Let's step back and look at the whole picture. We've traced the path from the broken sieve of burn shock to the complex math of Parkland and Muir and Barkley.
We really have.
We've navigated the specific dangers of vasopressors, the unique fragile physiology of pediatric burns, the destructive cannibalization of carbohydrate cycling, and the array of chemical tools we use to hold back sepsis.
And through it all, the recurring theme is how deeply interconnected these systems are.
Yeah.
The fluid resuscitation you calculate dictates the edema. The edema impacts the tissue perfusion. The perfusion drives the metabolic acidosis. And the open wound acts as the unyielding catalyst for the entire systemic cascade.
Which brings us to a final provocative thought for you to ponder as you continue your revision.
Okay.
Considering how early excision physically removes the necrotic substrate and restores the natural barrier to bacterial invasion, well, think about how the sheer timing of your surgical intervention is the ultimate modulator of both sepsis and the hypermetabolic flow phase.
That's a huge point.
By excising the burn and closing the wound, you aren't just preventing infection, you are physically turning off the engine that is driving the entire systemic storm. You stop the carbohydrate cycling, you lower the core temperature, and you save the muscle.
The surgery is the ultimate metabolic medicine.
Yeah.
It fundamentally reframes how you view the timing of your operations.
Exactly. All right, that is all the time we have for this revision deep dive. If you want a specific concept clarified, or if you have a follow-up question on any of these formulas, drop a comment or question wherever you are listening right now.
And remember to hit follow.
Yes, rate the show if you learned a high-yield exam fact today, and grab that premium subscription for the Journal Club and Clinical Cases episodes. Keep studying hard, and we'll catch you on the next deep dive.